Welcome to our first webinar. This is going to be something we're going to be needing to do more of in the network as we progress, certainly for this year, and we have reconvened our training and education group to start thinking about that. So this particular webinar is focusing on sharing ideas and best practice in Greater Manchester around remote working, and obviously the rest of the training programme will focus on different topics, and we'll release information when we've made some decisions on that. The agenda today has slightly changed. One of our speakers has had isn't able to present today, so Natalie Green isn't able to present from I think she's talking about flutter consultations on explaining flutter valves. So I'm going to kick off and just talk a bit about housekeeping, and then also I'm going to talk briefly about the specialty guidance that we have and the national guidance remote working in teams. We've then got, and I'd like to devote most of the session really to remote, to the different examples of best practice that we've got. So we've got a number of different speakers who are going to talk for about 5 minutes, and then we've got a Q&A session at the end, which is designed to be for all of you. So Chris is monitoring that via the chat function. So I'll just kick off and do a little bit of overview around what the guidance says and what currently we're doing in our teams, because we did some scoping a few weeks ago. So why work more remotely? Well, that's fairly obvious. We've been forced to work differently during the pandemic. That's partly to reduce virus transmission, but it's also to help shield our patients. And we've also got staff now self-isolating, and it's very likely this is going to continue in the longer term. So we're going to have to live with low levels of viral infection for a while. So it has been a long-term ambition of NHS Digital. They've been trying to get this done for quite some time, and certainly Nick Hancock, the current health secretary, who comes from a family, I think his family owns some sort of technology company, he's been very keen to push this in the NHS, but I think has been frustrated by the way that the NHS works, as we're all aware of. So the pandemic has in fact accelerated implementation of things that we probably should have been doing already. It's fair to say that I think the dump of money into the system has been helpful, and there's definitely more hardware, so iPhones, tablets, computers, laptops are more available, as well as the software platforms to use on them. And I'd say there's probably more proportional information governance, although I do get the sense it's creeping back to a little bit of computer says no approaches. So in terms of why we should do it more, well, obviously it's part of our agenda anyway, and it does potentially increase the capacity in our clinical teams, especially those working in community, and it potentially provides more accessible and convenient services for patients. So, and this is out with obviously the infection aspects. So these are things we should be considering anyway. So we need to consider, though, that not everybody can access digital technology, and that might be due to the lack of access. So there's lots of people who don't have smartphones, who don't have Wi-Fi, or are just unable to use it because they might be quite elderly and it's not part of what they do on an everyday basis, or it might be as a result of their conditions. So we've got Jill and Lucy talking a bit later around aphasia and how that patient group might be more challenged to engage with us if we use digital technology to help manage their care. Virtual working isn't going to replace some face-to-face contacts, as we do also need to do physical assessments and actually see people in person, and some of these things can't be done remotely, although we are looking at things like blood pressure monitoring that could be done in the community, with people either being prescribed a BP monitoring kit by their GP or perhaps borrowing one from their community pharmacy. So some of these things are being worked through. There's also a limited evidence base for some of these more virtual consultations or virtual ways of working. So we do need to consider, as we move along, how we measure the impacts of what we're doing, so that we can develop a better evidence base and understand what works and why. So I'm not going to go through all the guidance. This is just a bit of an example. At the bottom, I've got a link there for our digital health page. We've got a page we had in existence already that talked about apps and various bits and pieces, but we've added quite a lot more resources on that. So you can access that to look at it in more detail. But there's some national guidance on remote working for community teams, which was drawn together through NHS England. There's an NHS specialty guide on the management of remote consultations in secondary care. That's not specific to stroke. And then the GIRF, Getting It Right First Time, and the Oxford ASHN released a document that one of the sections on it was around developing virtual clinics for managing TIA and minor stroke during the pandemic. So that's more medically focused. There are a number of different professional guidelines. So the Chartered Society of Physiotherapists, for example, has got some, and there's some for OTs and some for speech and language therapists. So I would urge you to have a look at your own professional guidelines, because quite a lot of information has been provided on those different professions. Right, so just finally, really, in terms of the guidance, they all cover similar sorts of things in slightly different ways. It's around when you use a remote consultation, so which patients is it suitable for, and what staff perhaps potentially could be using remote consultations, bearing in mind that we've got staff that are still going to need to be self-isolating potentially into the future, and what sort of activities should you be using these kinds of working arrangements with. The guidance tend to outline how you might go about doing it, and particularly focused on the technology and also the information governance and the safety sides of that. So the different guidance say slightly different things, but they all seem to cover, having looked through them, they all seem to cover these sorts of areas. And just to say, how are our teams working? So this was scoping we did probably a couple of months ago now, right at the start of the pandemic. And so I'm hoping that things have got better and some of these issues have gone away, but there was definitely inequitable access to hardware, or things like cameras and sound being switched off on computers or laptops, lack of access to tablets and smartphones, and definitely a lack of ability to upload software, and also access systems like NHS systems like EMIS. So if you're going to work more remotely or work from home, then potentially you need to have access to some of these different things. So there's a big piece of work being undertaken by IT departments, I think, at the moment to work through these things, and that presumably will continue. It's still slow getting around some of the information governance. I think initially there was a sort of everything's okay, anything goes approach, but that seems to have trickled back into perhaps old ways of working. So I know that some teams are still grappling with the computer says no approach of some trusts. There have been concerns about the Zoom platform, and I did hear a concern about Attend Anywhere, but only secure platforms are now used, and obviously most of us have now switched to using Microsoft Teams. It does appear from the conversations we've been having with our different teams, the community teams seem further advanced in implementing remote working, and that's mostly because they're not able to visit unless visits are deemed essential. So I think there's more of a drive for them to potentially see patients remotely. There are different platforms that are being used, and there are different activities being deployed by the community teams. This includes triage, assessments, therapy itself, consultations, and also MDT meetings. The stroke unit teams seem to mostly be using phone calls for TIA clinics and moving on to perhaps using some different platforms for remote consultations, but it's definitely not as widespread as in the community teams. So that was all I was going to cover, and I think now we'll move on to our different speakers who may or may not choose to show themselves. So the first we've got is a speech and language example from Bury Community Stroke Team. So I'll hand over to Ali. If you just want to let me know when you want to move the slides on, then I can do that.
Thank you for having me here this afternoon to speak. These unprecedented times have really meant a quite rapid need to change in our service. And the current approach in our team is that we're using a mix of video, face-to-face and phone calls to see our patients. We're using the Fleming AccuRx software, which the trust has approved at the moment. And that's been quite useful for most of our patients. It's a fairly easy setup. Next slide, please. So what have the benefits and challenges been with our patients? I think the main benefit really has been that we've actually been able to provide therapy, which is surely what we're all wanting to do. So we've actually been able to see people possibly more frequently than we would otherwise, in terms of being able to go out and see them and reduce the risk of us transmitting any potential COVID symptoms.
Sorry.
And we've been able to provide therapy which perhaps needs a face-to-face element to it. So particularly in speech therapy, sort of apraxia type work is quite important. It's not really possible when you have a face mask on. It's very difficult to do. So the video calls have been useful for that aspect. We've also been able to the video calls allow us to get other members of the MDT involved if needs be. So if something crops up in a discussion, perhaps a medication need, we can go and grab a nurse from the office and get that sorted quite quickly. So that's been a real benefit. I feel there's potentially a reduction in the patient therapist hierarchy as well, something that we try to avoid anyway, but potentially because it's all new technology to a lot of us and we're getting used to it, it gives us an opportunity for patients maybe who have more knowledge of technology or or perhaps are learning things as well to realise that we're not necessarily always the experts in everything. So sometimes we get things wrong, we struggle with things as well, and perhaps that might help that relationship a little bit more. Something we've not used it for yet in this team, but hopefully in the future, is for training. So we're hoping to use this technology maybe for people to come in on sessions and observe sessions with patient consent. We're hoping that will support our patients and our students possibly in the future, and also our assistants as they do their training. There have been some challenges, major challenges around connectivity and delays and unfamiliarity with using the technology. We're very reliant on the patient or their family members really to understand how the tech works and to problem solve it, and we don't necessarily have the luxury we would have done before this pandemic of being able to pop out and show someone how to use something, and that's definitely been a bit of a challenge. We're very lucky here we're able to have a space that we can come and do our sessions in, but I appreciate that's not always possible with everyone and their different working situations, and that can be a challenge. And it's really not suitable for all, and obviously we've got Lucy and Jill joining us later on, and I think they probably will have a lot more to say around the difficulties and challenges of having a communication difficulty in accessing some of the video technology. Also, alongside that, there's definitely new pragmatics and ways that we have in terms of rules for video calls, and so I think we've all had some of this. Anyone getting used to using video technology for social reasons as well as for work, and the pragmatics around it are slightly different. And if someone already struggles a bit with their cognition and their communication and knowing when to come into a conversation or when to end it, that can make it very difficult for video calls. And finally, someone's self-image as well, particularly for any patients who maybe have got a new facial weakness post-stroke. Suddenly to having to look at yourself on the video for an extended time really could be quite disheartening for someone who's maybe struggling with that aspect. So it's definitely something worth considering. Next slide, please. So just a few ideas. I probably could have said an awful lot more, but I've only got a very brief time. So I definitely say make sure you're very prepared when you're doing your video calls. So make sure that you've got everything available to you at hand. Make sure your room's really set well, you've got good lighting and a plain background, and there's not too much noise going on outside. And where you can, try and use things like the camera on your computer or your tablet. So think about using flip the flip screen of the camera to look at resources on the table and then go back to yourself. Think about using the share screen option. That's what's being used at the moment, so you can show documents to somebody or websites. And also you can use things like highlighting and annotating, so use that technology to support people. Think about the length of your sessions and make sure your patient is managing, because it can be quite a high cognitive load to have an extended video chat with somebody. And definitely make use of all the free resources that are available at the moment. So particularly in education, there's an awful lot of free stuff available that you might be able to utilise in speech therapy and possibly for OT as well. And things like virtual tours of places. There's lots of museums and art galleries and all over the world, places that we can go to that we wouldn't normally be able to access. And actually that could be really useful in some therapy situations. And finally, we've here over in Bury, we've created some support for our patients to think about how their family and friends can support them in communicating using video chat in a social way as well. And that's something that we've shared with some of the other speech therapists, and I'm happy to share if you've not got hold of that already. Last slide, please. So finally, we know this is a marathon and not a sprint, and Sarah's already mentioned about that. It's really important that we uphold the integrity of our individual professions. Video conferencing and video therapy can be quite beneficial, but it isn't quite the same, and also it does depend on the therapist involved. We've got to think about the patient benefit versus the cost saving for our patients as well. And I think thinking about auditing and outcome measures is really what we need to be considering in the future to really show the benefit of this and also where its limitations lie. I've put my email at the end there, so if there's any questions that come up after this or after this has been recorded, feel free to email me as well. Thank you for your time.
That's really good. Thanks, Ali. It was a really good, I think, good to kick off and a comprehensive overview. If you've got any questions, please pop them in the chat box. I've also realised I completely forgotten to warn you all about my hair, which is developing its own gravitational pull and orbit. So apologies if you're a little startled when you've seen me with my video on. So we'll move on, and we're now going to move a little bit sideways in terms of our geographical location, or down, I think, to North Manchester. And Karen's going to give us an OT perspective.
Hi, I'm going to be honest, I'm struggling to see my presentation, the presentation on the screen. So I've got it open on another computer, so I'll make sure I don't lose anything.
Yeah, that's fine. Just tell me when you move slides along.
All right, okay, thank you. So to set the scene for my case study as such, so if you want to put it on there to slide, which would be in essence slide 2,
Case study.
the case study.
Yeah.
To set the scene, I had a very challenging patient, to put it politely. The lady's 76-year-old with atypical Parkinson's, but this is a woman who wasn't necessarily engaging in follow-up assessment. She wasn't engaging with services, and the communication of her diagnosis of atypical Parkinson's seemingly had got lost over the 12 months between the consultants at the hospital and the GP and the family. So when the lady was referred to us, there was no thorough understanding of why this lady was deteriorating. Her posture was declining, she was developing contractures in her upper limb, her cognition had been going down. The family felt it was just linked to arthritis and was linked to her giving up. So it became quite apparent that the first thing that we needed to do with this lady is to make sure that we needed to confirm her diagnosis. If you want to put it through to slide 3, please, Sarah.
Yeah.
Okay, moving across. So when we looked at the practicalities of actually getting this lady assessed by the doctors at the time, the lady, like I say, hadn't taken up on board and hadn't engaged with other outpatient services. She was reluctant to leave the property to actually go and see doctors. Unfortunately, all outpatient appointments had been cancelled at MRI, and she was considered to be vulnerable to COVID. So we decided that we would look at the use of Accurix to support MDT working. Now, again, in view of this lady's diagnosis and presentation, she wasn't able to actually use remote technology herself. Her presentation was as such that actually she needed to be facilitated within the assessment process as well. So the first initial video conference that we did with this lady was with the Parkinson's nurse. So myself was with the patient, because what we wanted to really do is limit exposure to any unnecessary viral loads that didn't need to be there. So we limited the visit to the patient in the property with one therapist, and we Accurix the other consultants and specialists to provide expert advice via video conferencing. So within the first video conference, we were able to, the Parkinson's nurse was able to identify several features of Parkinson's, including the mask-like face, the tremor, the contractures, cognitive decline, as well as a few other bits and pieces. So from there, we realised that, you know, at the end of the day, we've got the support here. So with the support of our colleague, we approached Bex Davenport, who's the movement consultant at Manchester Royal Infirmary, who was the team that had initially diagnosed the patient. And she agreed to participate in a video conference assessment for us. So within the second video conference via Accurix with the patient, sorry, you need to move to the next slide, please, Sarah.
Yeah, done.
So moving forward with that, we were able to identify with that Bex Davenport and confirm her diagnosis. So again, in the room was myself as a therapist with Bex working in her office at MRI Hospital, conferencing over the phone. So again, facilitating the patient's participation in the assessment, we're able to confirm the contractures, confirm the diagnosis of atypical Parkinson's, and we're also able to add in a dementia element to her diagnosis, which hadn't been identified before. From this way of working, we were able to plan some way of activity to engage the family in the understanding of the diagnosis and to communicate the diagnosis to all health and social care professionals involved. We've been able to plan to review further cognition, swallow and nutrition, and medical management of the Parkinson's. We've got added complications with the lady in terms of her behaviours and a violent presentation towards some of her carers staff. So we continue to work down the route of looking at her capacity, again, with myself in the room facilitating and doing some remote work with the psychologists. So we've got further video conferencing planned for this lady with the consultant to bring into the room to have a wider meeting with the families and with the GP. If we move on to the next slide, which is my last slide, Sarah.
Yeah, done.
We just feel as a team, we've got so much potential to use Accurix to push forward with our patients who are non-concordant, our patients who will not go to follow-up assessments, and our patients who are very dense. And that takes a lot of time, energy and manpower to take them to a hospital for follow-up assessments, particularly as towards the end stages of the degenerative conditions. So we feel that there's potential to maximise participation within these assessments while still maintaining social distances. Accurix in itself, we've worked out we can invite up to 4 people into the video conferencing. So it's not just me and the patient. As such, it can be me, family members and other consultations within the room. We're able to use it to actually look at it from, the person does need to have some form of assistive technology or smart technology, but it doesn't have to be via a smartphone. We've worked out we can link iPad to iPads and other computer technology to actually make that happen. We've got the potential to engage the outpatient and community services and get them to work together so much more better in terms of follow-ups, because we're doing joint assessments together, and we've got the capacity to actually engage those patients who are non-concordant a lot easier through these technologies, because actually the effort of them attending these appointments and attending follow-up is minimal on their part. And that's it for my presentation. If there's any questions. I mean, in fairness, this is the one patient we have done it on so far, but we have got another one patient where we're planning to follow up via this way with a different consultant as well for the same reasons. He refuses to go to outpatient appointments to see his follow-up consultants for either his spinal or his neurology appointments for epilepsy. And he won't fully engage in therapy. So we're looking to expand this a lot further with our patients.
Thank you, Karen. I think it was a really interesting case study. So I'm going to, if you can put some questions in the question chat box, we'll come back to you. I'm going to move us along because I'm just conscious of time, and I don't want to have first webinar to overrun, but thank you very much for that. So if I can ask our very own Jane Malloy to step up and possibly switch herself on. You might want to turn your video link back off, Karen, but if you're ready to go, Jane.
Okay, thank you. I'll spare you my video. The title of this around consultations via Attend Anywhere has been somewhat hijacked by the fact that we've ditched Attend Anywhere at Salford now, and we're between systems. So I thought I would just talk about some generic thoughts about remote video consultations, and particular sort of governance and issues around medical consultations. So we know that there are big considerations with regard to IT infrastructure, cultural shifts from having face-to-face consultations to remote consults, and how that makes us all feel as clinicians and as patients. And we know that there have been repeated trials over the last 10 years showing that remote consultations are acceptable and effective for selected patients, but we've been pretty slow to adopt that over time. So where has that been? Next slide. And places where they've successfully introduced remote consultations before COVID have been united by having innovators and champions moving services forwards for them, and what was termed sort of agents of change. And I think the biggest agents of change at the moment is COVID-19 itself, and the fact that we were expecting for that to impact on us in the short term, but that it's probably here to stay at a lower level for longer. We do therefore need to increase our remote working, but we shouldn't just jump in without thinking about what we're doing. And I think that the comment that you made actually earlier around it's a marathon, not a sprint. We thought we were in a sprint and needed to adopt things quickly and ask questions later. But as this sort of stretches on a bit, we need to probably take time to build more sustainable systems. Things that have been issues are around how we interface with our local IT systems, how we consider governance, what system do we use, and people have referenced already Attend Anywhere and AccuRx. Attend Anywhere is widely in use in Scotland, and it looks as though AccuRx is going to be the system that ends up widely in place in England, but I have to say that I have no experience of using it as yet. The second generation platforms like Attend Anywhere and AccuRx do allow some benefits in that they give you a virtual waiting area, so the patient clicks on their link and waits for you to join them. It's pretty dependent though when you're having quality peripherals around your cameras and speakers, microphones. I would really love to have a headset. I've been wanting a headset now for the last 8 weeks, instead of which everyone around me has to listen in to my calls at the moment. The consultation needs change. So we've all been trained about how we talk to patients and how the format of our consultations run, but there are implications to this around how we then have to have phases of our consultation around how we set things up, having that social interaction. What do we do compared to watching the patient come in and shaking their hand? How do we start our consultations now? The clinical interaction that happens during that consult, but we have to be prepared to repair when things go wrong, if the camera fails, if pixels are out of sync, if the microphone is not working. I know that Claire had some issues with our audio earlier around how we support each other in these sorts of consultations. And we need to also be sure about maintaining good medical practice. There's no next slide. And definitely, we don't have one size to fit all of our services or all of our patients, and not all patients are going to be suitable. I've put a link in here with regard to a paper that's just released in the BMJ in the last week, and it's a Trish Greenosh paper from Oxford, sort of summarising their qualitative studies in remote consultations and with some hints for the future. Next slide. What does the GMC say about remote consultations? And that's something that as clinicians we worry about, how we should be running things, how we document things. And so the GMC are clear in stating that they're happy to embrace new innovations, but that there have to be other other bricks in place if you're going to construct a good and robust consultation. And the next slide. It's just a copy of the infographic from the GMC website that I referenced in the link in the previous slide. So it's a little bit small to read on here, but essentially what it's saying is it can be great to do a remote consultation if the clinical need is straightforward and if the treatments are straightforward, if you've got the right access to info, if you don't need to examine the patient, if you've got some safe prescribing systems in place, how you deliver those medicines to the patient, and actually the patient having capacity is a big issue, just as with the previous speaker, that are people not coming to appointments because they don't have capacity, or is it around the travel constraints and other issues that make it more difficult? Remote consultation is not quite so good as there are complex clinical needs, although having the Accurix with up to 4 people engaged does at least allow an MDT discussion with the patient. If there are more risky treatments to think about, if we need to examine our patients, if we don't have good access to their info, then those things can really limit and make a consultation less safe. Next slide, please. Sarah's already listed the link around the British Association of Stroke Physicians guidance around adapting stroke services during the pandemic, and there are useful links there also around use of telemedicine, for instance. Next slide. So for the moment, what are the specific TIA and stroke issues? We're lucky in a way that TIA referrals are around half of what they were before, so it means we've got some breathing space. We're not sure whether that's because patients are behaving differently or referrers behaving differently, but the reduced numbers in our services means we've got a little bit of time perhaps to straighten things out. There's a recommendation that we do virtual triage of our patients. That's something that we've perhaps wanted to do for a longer time. Is it possible perhaps to move some of the patients to different services if they're inappropriate referrals? And that virtual triage system can also be used to support preparation for the patient as well, knowing what they have to have ready for their consultation. At the moment, I'm not aware of any service for TIA around Greater Manchester using video support to consultations. Most of us on the stroke unit calls are reporting use of telephone interactions for the moment, with backup of face-to-face where needed, although systems are moving along. The thing we lose by not having the video is we lose those non-verbal cues. As again, we heard two speakers back, we lose the ability to do examination. And if we've got a video set up, we need to explain to our patients what we need them to demonstrate. There are system requirements which think about where we are doing our clinics from. If it's from the dining table, then it's going to be annoying if the next door neighbour starts mowing their lawn, and annoying when the children come to bother you for whatever it is they think is more important than what you're doing. Useful to warn the patient to have a witness available, and really important that you've got prescription availability and how those medicines are going to get to the patient. Next slide. So we need to have some backup around how we organise face-to-face. If we've got doctors who are doing remote consults because they're in shielding, then who's going to do the face-to-face for them? We need to think specifically around the diagnostics, and it's difficult to see how you can do your stroke and TIA assessments without having your 12-lead ECG or even a single lead ECG, so you know what the rhythm is doing. Being able to access blood pressure, pulse measurements. And what we maybe need to think about is in continuing reduced visits to hospital sites, might we need to be thinking around community hubs and investigation pods? I'd be interested if anyone's got involvement in set up any of those types of resources for the moment. How do we monitor blood pressure? Sarah talked around prescribing blood pressure monitors. If we're going to prescribe those, how do we tell patients to use them, and what monitoring strategy do we use? What advice do we do around following that up? A suggestion on the BASP website is that we still do that follow-up 1 month down the line. If we're going to do imaging, where do we do it? What modality do we use? And if we're going to do an MR scan, and if we need to look at someone's carotids, we should probably be doing MR and MRA in one sitting, not have 2 visits for Dopplers and for an MR scan. We need to be really clear about how we document what's gone on. We need to document what modality we used for our consultation, whether that was telephone, telemedicine, or some other service. And actually, the other challenge is that we're meant to be doing all of this within 24 hours of the presenting event. And how do we fit all that in? It feels as though that's quite a challenge, manpower and logistics wise. Next slide. So how do we balance implementation? In some ways it's disappointing we haven't got a good video clinic that we can use as an example for Greater Manchester yet. We did ask Peter Moore, who's implemented video consults up in North Cumbria, if he would be able to join us this afternoon, but so sorry he wasn't able to come, and so you do have me. If we're going to put things in place speedily, it's really important to get it right first time. And we have spent some time setting up different systems, certainly at Salford over the last 8 weeks, and we still don't have a good system in place. Now that we know that COVID is probably with us for perhaps 18 months, if we're being, I think, realistic, and perhaps longer, then again, we need to get something that's going to be sustainable for the longer term. Whichever of the second generation platforms we look to use, we need to think around how we can make those solutions interface with colleagues, admin, diagnostics, colleagues around the region, how we organise remote investigations, and we have to choose the silver lining that we want to keep longer term. Thank you.
Thank you, Jane. I'm going to move us straight on, if that's okay, in the interest of time. If you've got any questions, I noticed there are a couple of doctors online, so that's great. Put them in the chat box. Moving straight on to Harriet. I don't think you've got any slides. Harriet Allen, definitely silence.
Sorry, just unmuting now because I thought Natalie was up before me. That's why.
Yeah, sorry, she's not able to attend, so please shoot.
No worries. So I think I've been asked to just talk a little bit about a audit that we've started doing in the Trafford Community Neuro Rehab team. So I think the rationale for the audit everybody's already talked about within all the different presentations about why using AccuTreat for remote consultation. Primarily for this audit purpose, it was in physiotherapy. Primarily within neuro, although now it's been picked up within different areas of community provision within Trafford Local Care Organisation. So the aim of our audit was basically to determine whether AccuTreat was an effective treatment and was a good way of replacing some face-to-face contacts, or whether it was just a stopgap during this period of time when we couldn't actually do those face-to-face contacts. And so basically to determine whether in the future it was something we did carry on with. So the main standard for our audit was using the GAS goals, as we do with all our treatment consultations, and the achievement of those, so that we knew that the treatment had been effective and we had achieved what we'd set out to do. And obviously they're supported in all the RCP and NICE stroke guidelines. So our method, it was initially we took our caseload and we triaged our caseload to discover how many, our waiting list, to discover how many patients on our waiting list wanted or could be treated by AccuTreat in terms of our inclusion criteria. So our inclusion criteria were if anybody consented to that treatment modality. Quite a few patients had access but actually didn't want their treatment via AccuTreat, and they'd rather wait till they had face-to-face. They obviously had to have a neuro condition, otherwise they wouldn't have been referred to our service. They had to have access to the technology, as we don't have the means to lend that out to patients at the moment, although that is something that we're looking at applying for charitable funds for. And we need to ensure that we could complete the treatment that we needed to complete via remote consultation safely and effectively. The main exclusion criteria we put in place with regard to anyone with significant cognitive impairment, which would limit their ability. From a speech perspective, we put that as a query and assess that on triage. and any language barriers in terms of if an interpreter is required. We haven't got access to that sort of service at the moment for AccuTreat, and therefore we couldn't use those. So when we had a look through our initial waiting list, 25% of our neuro caseload consented to treatment via AccuTreat, and 35% of our stroke waiting list consented to treatment via AccuTreat. However, we're not just stopping at those, we're going to have it as a running audit over 3 months. So those numbers will change, and we'll have a final percentage at the end of the audit period, which we've initially set for a 3-month period, so that will take us up to the end of July. In terms of collecting data and what data we're collecting within the audit, we're going to do patient satisfaction questionnaires with patients, which we've designed specifically to reflect their AccuTreat treatment. We're also completing staff questionnaires to see what their opinion is about how it's completing and how well it's working. We're also extracting data from our electronic recording system, which in our case is EMIS, and from the patient notes as well, because that's the only place where we can find out in terms of goals set, in terms of their GAS goal objective recording. The outcomes that we're looking for from the audit are basically the number of patients who achieved their GAS goals through purely having treatment via AccuTreat. We also want to have a look at the length of treatment, so the length of stay, and whether that's any less or any more as a result of using AccuTreat. And tied into that is the number of hours that we are treating the patient for using AccuTreat compared to face-to-face contacts. As I say, the audit's still ongoing and we don't have any more data. We don't have any data to present at present, although having a chat to some of the staff about who are inputting data into this audit, we are finding relatively low numbers on the uptake. As you heard, 25 and 35% have consented, and of those, about 50% are needing some face-to-face treatment at some point. So AccuTreat, although good for now, maybe isn't the most effective way of seeing them in the future. We're also finding that treatments aren't particularly quicker, although you would have thought a reduction in the amount of travel would be a good positive things in terms of staff being more efficient and seeing more patients in a day. We are tending to find that staff are spending a lot more time assisting patients in accessing the AccuTreat, and then spending time setting it up and getting it in a good position, or if they want to see a patient doing a particular thing, discussing where they put the camera, where the camera lies. We've had stories of staff staring up a patient's nostrils for 45 minutes while they try to reposition the camera correctly, and also where a patient's wife, when we were trying to look at a patient's foot, the patient's wife didn't know how to switch the screen, so was lying on the floor next to said foot, and luckily she was fully mobile and able to get back up herself. So we are finding those sorts of things anecdotally, but hopefully with the data collection method that we've got in place, we'll be able to have some solid data to support whether it's a treatment modality we carry on with particular cohorts of patients, moving through to the future. And that's all I was going to say about it. So if there's any questions, please let me know. Thank you very much.
Great, Harriet, and I'm sure if you plan to write it up and you'll be able to share that with us and we can circulate that through the network. So I'm just going to move on, and we've got Lucy and Jill from Speakeasy, and they're going to be talking to us about aphasia.
Okay, thanks, Sarah. Can you hear me?
Yes, perfect.
Yes, I'm on. Okay, thank you. So it's Jill Pearl from Speakeasy, speech and language therapist by background. So what we did as our response was to look at all our membership back in March to identify what resources they have access to, what can they use in terms of technology, what potential have they got. And you've heard already about the challenges with aphasia and processing issues. So we looked as well at what support people have got in the background to enable them to be doing more. Then we had the conversations around what people need and want in the current situation, which may be different from what they wanted or needed back in February, say. And what we did then was to try to match these two together and look at what our offer should be. And we designed something to include carers and people with aphasia that we've called our Speakeasy at Home service. So next slide, please. In addition to this, we have been, thanks to the ODN, we've been offering our service more widely across Greater Manchester to take referrals from stroke teams and speech and language therapists. So this is to support teams who are struggling at the moment with capacity or who need something in a different way. We've used our team of speech therapists here to triage all the referrals that we've received. And we've tried to either slot them into the current Speakeasy offer or to develop new support according to their need, because our pattern of support is changing all the time. Our Speakeasy offer is not static. It depends on who we've got and what their needs are for any one time. Parallel to this, we've also been developing aphasia accessible resources, which are being shared widely, not just in this area, but internationally as well. And we've recently been working with the Stroke Association as well to develop some accessible resources about how to get online, how to use Zoom, how to use Skype, etc. And they have literally just been released. So you can check out our website or Stroke Association website for those. Next slide, please. This is a very busy slide, but this shows you a snapshot of 2 weeks ago what we did. We're now up to supporting about 85 people with aphasia and carers. So I'm not going to go through all of this, but you can see that there's a variety in this, and the variety is key because it makes it individual, supporting each person. It's not all about therapy. Some people are having therapy, some people are not. It's their choice for what suits them for living with aphasia at the moment. So I would say that most people are receiving at least 3 or 4 of these different options a week, and we've now included communication partner training courses as part of our pattern, and these have been very popular. If you're wanting to refer, please do, but could I ask that you don't use the office phone or the office address, because we're working remotely and we're not accessing those at the moment. So that's what we've been up to, and for the comments on how it's working and the challenges, I'm going to pass you on to Lucy.
Thanks. So I'm going to talk about the experience of people with aphasia during this time. It's been really interesting for me because I've been involved largely in setting up video calls for supporting our members, but because I have aphasia as well, the challenges go both ways. So firstly on the slide, yeah, so our members are feedback is really good, and they're very grateful to be connected and feel a lot less isolated than they would have done. But I suppose the best way to say it is that if you think about all the challenges that are present with a typical person accessing especially video calls, all the things that is a little bit more difficult, and all the things that can go wrong are all there for a person with aphasia, but are exacerbated. So the technology can be really challenging and very frustrating. So it took us a good 2 weeks to set up the platforms with our members remotely, so that we could have video calls with them that would be similar to what we do at Speakeasy, and that was probably the most challenging part of the whole thing. Ali mentions in her talks that it's difficult for speech therapists because their patients might be relying on someone else to have the wherewithal with this technology, and that's very much the case for our members. So it can be really frustrating, especially if you're on your own and you don't have anyone else, and we can't go and be with our members and help them with it. It can be really challenging. And if you think about the number of steps that you go through to get onto a platform like this, if you've got aphasia, by the time you get there, you're already pretty tired. So your video calls are a lot more tiring than a face-to-face conversation in person. So what we normally do at Speakeasy, we have once a week we have a 2-hour session, which is normally a presentation to our members, and then we divide up into small groups and have supportive conversations. So we're trying to mimic that with video calls, but as you all know, if you're using video calls for social reasons or for work, the cues are different, so there's a lot more interrupting and everyone trying to speak at the same time. The connectivity problems are very distracting and quite tiring when you have aphasia. And although the video calls are preferable probably to the phone, because you can see the other person that you're speaking to, the way you read the body language is very different, I think, especially for a person with aphasia, and it's not as easy as in real life to pick up those cues for conversation and know when you're supposed to talk, and also to follow what the other person is saying. One member told me last week, I thought this was really interesting, she hadn't realised actually that she lip reads until now, and she can't do that on video call. So I think the things coming up that we maybe wouldn't have thought about ordinarily. And we found that small groups and limited time make the whole thing easier. We always try to limit our group size when we're having supported conversations at Speakeasy, but we found that more than 4 makes everything more difficult for the reasons that I was just saying, and also that people can't tolerate the same amount of talking and on a video call as they can in real life. And I know from a person with aphasia's point of view, this, for example, this hour, it's enough for me. I can just about take it in, and I won't be able to do anything that uses my brain very much after. And it's very much the same for having these kind of supported conversations. So where we might be talking with a group, with a volunteer, supporting conversation for an hour in real life, video calls, some people can only manage 10 or 15 minutes, or maybe half an hour. I think the group that I get the longest with is about 45 minutes, but that's 2 people that know each other very well. I think that the kind of the take-home message is that using these remote platforms or the video calls is absolutely the best that we've got during this time, and we need to use it to help our our members and people with aphasia feel less isolated. But the reality is that it's nowhere near as good as sitting down with someone in person to person, and being able to support that conversation with a person there. So yeah, thank you for listening to me speak.
Thank you, Lucy. That was, I think I felt quite strongly about having the other side of the fence on this particular call. I'm conscious of the time and that we've perhaps run over and tried to cram too much in. I know we've got Becky from the Stroke Association who hasn't got any slides. Becky, are you able to perhaps do a couple of minutes, and then we can maybe quickly come back to the questions and perhaps run maybe sort of 5 minutes over?
The other one that I was going to mention was our exercise program. So some of you might know in Oldham, Wroxham, Stockport, we delivered exercise, working with the gyms and using later life instructors. Unfortunately, obviously, because of what's happened, we're no longer able to do those. But what we have done is moved them online. So Eamon is working with the Leisure Life Centres, and in Oldham, Stockport and Rochdale, we are now delivering sessions online. So it's chair-based exercise or low-level exercise to participants who already attended. So we have a good idea of what their ability is like. So we've started doing those, and they've turned out to be really, really valuable. One of the comments we had was from a participant's daughter who said they've noticed a massive decline in the mum's physical health because they've not managed to go out and she's not doing what she normally would do. But now she started doing these exercises with Eamon on a weekly basis. They've noticed she started improving her physical health. So there's some really positive thing that's coming out from that. And the peer support is really, really valuable. What we are doing is, and this is very initial conversations, looking at how we can offer that across GM. So we only started doing this a couple of weeks ago, but we are talking with Eamon about how we offer these to other participants, not just in those areas. What I'll do is I'll stop there because I'm really conscious of time, and then I'll pick up when we have the next one.
Yeah, so I think what would be really useful is perhaps to have maybe a follow-up one which really does focus on the patient experience of consultations. This was really a little bit about sort of clinical delivery, and actually maybe about expanding on some of the things Lucy's been saying, and also some of the support the voluntary sector are doing. I don't know if, so I'd like to thank all our presenters for giving some really different perspectives, I think, of how things are being delivered, and particularly Lucy for telling us how it feels. Chris, would you like to come in with some of the questions? We've probably got 2 or 3 minutes to go through any questions that might have been raised.
Yeah, no problem. Can you hear me okay?
Yeah.
Okay, so yeah, we've got 2 questions. We've not had any questions on the chat through the group, which is testament to how good the presentations probably were. We've got 2 questions from Paula Beach at Salford in the acute setting that were sent over to us and I open it up really to all speakers to unmute yourselves and come on if you can answer the questions. So Paula's been looking at, I think, the differences between Accurix and Attend Anywhere, looking at views on the differences between the 2. And the second question was also around what people have used for family case conferences in the recent weeks, and if anything has been used in that setting. So if any of the speakers are able to come forward and offer any opinions, or even anyone who's in the call really who maybe not as presented but has got an opinion on or some evidence of family case conferences using remote working.
To be honest, we haven't used Accurix as a family case conference, but Accurix itself has the potential to add other people into the room. So you add those additional numbers in. So you could, in theory, bring a family member into the room on Accurix.
Okay, thanks for that, Karen. I don't know, Paula, if you want to come off mute and ask any further, or if obviously I asked the question in the way it was directed.
Yeah, no, that's fine, and it's helpful to have picked up through today's webinar that obviously you can involve up to 4 people, and you can certainly involve relatives. I guess the difference thinking about family case conferences in the hospital setting is the patient isn't always directly involved, or it's about bringing the relatives in from the outside. So I think I need to do a bit of exploration about that, about the best format of doing it. We're obviously talking to people on the phone, or we are sometimes doing socially distanced, especially arranged bringing relatives in at the moment. So
Okay, thanks for that input, Paula.
I would just say, Paula, that I think that your concerns are right. I do think there is something around capacity here. So one of the advantages I've seen is that there are patients who've had multiple DNAs, often patients with epilepsy or people with alcohol excess in the background, who've never come to hospital appointments, and you feel that suddenly you're able to engage them and they can't escape the phone call, although some of them do escape the phone calls, some phones are left switched off. But I do think there is something around how we make sure that, just as we're having best interest meetings without patients in the room, if we've demonstrated lack of capacity, how we do that for outpatients. I think that's a really good question.
Yeah, well, I'll do some more digging and thinking, and that, like, again, if we meet like this again, it'd be good to talk that through, or maybe we'll have an example by then. Thanks.
And I think one of the other things is around how we DNA patients if we can't get hold of them, what constitutes an unable to contact.
Okay, thanks for that, Jane. I think we've just got one more point I wanted to raise from Claire for anyone who didn't see it in the chat, but I've got one more question just come up from Naomi Bull, and she's asked any community teams using accurates for standardised cognitive assessment. So I don't know if you can put the answer in the chat. If you are, just while I go over to Claire for a second. So Claire raised a very, very valid point in the chat regarding the challenges in some professions for remote assessment. So Claire, I don't know if you want to just raise that point again, if you could, kindly.
Yeah, hi, can you hear me?
Yeah, I can hear you fine.
Yeah, it was around indemnity, and we've come across an issue where our professional body has said that they're not going to provide us indemnity insurance for vision testing if we do that remotely, because there isn't an evidence base behind it. So it's just really more of a prompt for everyone to look at their own professional indemnity provisions in terms of video calling and what we can and can't do and what we're covered for. I don't know whether anyone else has come across this.
I think from our practice with regards to accurates, it's very much with regards to who's in the room and what it is you're assessing. I'm going to be honest, we've never used it for formal cognitive assessments. But for a formal cognitive assessment, more often than not, you need a physical response from the patient within the room. And the way that we've been really pushing it is more from a follow-up perspective if it's with individual patients, or having one clinician in the room to facilitate the assessments, and having the experts outside the room on accurates to provide expert opinion, but also to provide direction, so we can give the feeling, the sense that everything else that would be missing from doing it face to face, we can still facilitate that by having one person in the room.
Okay, thank you for that.